Okay, so good afternoon to everyone. So I will give a really short overview. How was the implementation and commissioning of the SBRT workflow to treat SBRT patients. I will just present the physics point of view. If you have questions from the clinical point of view, we have also a poster regarding this aspect. So the idea is to use to treat the patients in a hyperfractionated way that requires a high precision and accuracy of the treatment. That means that along the entire radiation therapy chain, from the planning, from the imaging and the delivery, several aspects need to be changed or adapted to consider this hyperfractionated delivery. Regarding the delivery, is desired faster radiation to avoid to have more sources of motion and uncertainties, and we need to have also some way to make the motion management of the patient. So the challenge when we are speaking about SBRT and when we are speaking about thorax, liver, abdomen regions, that sometimes we have a poor correlation between the tumor and the breathing of the patient. Our initial approach was to use abdominal compression, as you can see in this image, that simply reduce the motion applying a compression in the abdominal regions. Another option is, instead to do this physical way to reduce the motion, is to use a deep inspiration breath hold. If you want to consider the motion, you can also do beam gating or beam tracking. So the idea of starting this project was to use to confirm this hypothesis if SBRT can be used to improve the accuracy of the treatment and also to reduce the radiated volumes. So our workflow in Heidelberg is to perform this hyperfractionated delivery using deep inspiration breath hold and using the line RT system. So a short trip to Heidelberg. So Heidelberg is a big hospital, and we have several available therapeutic modalities, and according with the kind of tumor, the patient is sorted to different machines. So in case of the line RT installations, we have 3 options, 2 Electa Linacs and 1 installation at the CT machine. This installation is a line RT installation, and is used to perform the patient training and to get the patient used to use this technology and to explain to the patient how will be the workflow in the treatment day to avoid to save some time at the Linac. So you already have some experience with LNRT. Until now, we treat around 200 patients using the ABH for breast irradiation, and up to now we have treated 12 SBRT patients with this technique. So this is a short overview. Our implementation started in 2016. Only with the left breast patients, and now we are introducing another locations. So the objective from this presentation, and to give the outlook and to give the actual status of the commissioning that we defined for our SBRT patients and adapted to our clinic and to our workflow. So regarding the commissioning have several steps that we defined previously. One of the first steps is how are we going to do this core-beam CT for each patient, because we are still going to do core-beam CT to have sure how is the internal motion of the patients. Define a protocol for core-beam CT. For the case of deep inspiration breath hold, need to be a short protocol, of course, fast. How reproducible will be the ABH state? How will be the core-beam CT matching? How will perform the line RT system when you are using VMAT or 3D techniques? There is any gantry blocking, any coach rotations issues? How can we define the different ROIs, the size of the ROIs, the location will be different for abdominal, lung patients. And then at the end we started with a clinical evaluation. How is the correlation between the surface and the tumor? the daily columnicities, which feedback can we get from this imaging, from the internal imaging of the patients. So the guidelines to define these protocols, this commissioning protocol was considering that all the patients will be treated in the electro linacs. The patient selection will be done during the CT acquisition day. That means during this CT acquisition, the patient will be coached to hold the breath during 30 seconds, will be tested if the patient can reproduce this breathing hold status frequently, which the radiation techniques for SBRT patients will be VMAT or 3D, always that possible using without flattening filter. All the patients will have daily CT, daily column CT, and if any shift is observed after the column CT acquisition, a new reference capture with a line RT will be performed, and the new imaging will be done. So along the study was used this for phantoms, dynamic phantoms to test the situation with motion. One breathing phantom that is quite useful because it's quite easy to use to test the system in a few minutes. The imaging phantom, the quasar phantom, and the MVQ phantom from Vision RT. So first task, to confirm how performs the line RT system, how is the accuracy of the system integrated in our treatment. That means that not only the line RT accuracy alone, but integrated with our LINAC, with our imaging system, with our TPS. So one of the first points to evaluate was the static accuracy of the system. So for that was simply to move the quasar cube with different positions and to confirm if the motion given by the shift from the laser's position or the motion measured with a cone beam CT, how is the accuracy between the radiographic information, the laser's information, and the line RT information. For that we use different positions, a little bit out of isocenter, in isocenter, different patterns, and we got results always below 1 millimeter, even for the situations where the cube is outside the isocenter. In the case of dynamic motion, so we use this Sears phantom, and we moved the phantom with different amplitudes, starting from 1 millimeter going to 2 centimeter, and evaluating how the line RT system is able to detect this motion, how is accurate to detect a small motion 1 millimeter, how is accurate to detect 2 centimeter. We got better results for larger magnitudes. For small magnitudes of motion, we can easily increase the accuracy of the system using the different ROI. But anyway, the accuracy of the system is always below 1.2, 1.3 millimeters for different ROIs and the different locations. Also important because in the case of the SBRT patients, the treatment can often take more than 10 minutes, so it's important to understand how is the signal drift along the entire treatment time. How is the signal changing, the line RT signal changing along the treatment. For 10 minutes measurement time, we got that the signal can change up to 0.3 millimeters, so not significant. So now defining how will be this column CT acquisition. So this new preset for column CT need to be a good signal, a good tissue contrast, reduce the dose to the patient because we are going to do this every day, need to be fast, so something around 30 seconds, and we also want to have a reduced signal, a reduced impact in into the line RT signal, because we are going to do the column CT during the time that the patient will be monitoring with the line RT. And this is two of the presets that we defined. We defined the preset for the left side lesions and the preset for the right side patients. both presets are around 200 degrees. The left side preset have less dose. We increase a little bit more the dose for the right side case because normally it's our liver lesions and we want to have better soft tissue contrast. For both cases, the imaging time takes around 40 seconds, so almost completely all the patients are able to hold the breath during these 40 seconds. We have an alternative protocol, but we never use it until now. If you have really, really big patients and we have issues to get a good imaging, we can do a 360 column CT, but the time will be more than 1 minute, almost not achievable for a majority of the patients. Now regarding how the signal, the line RT signal is affected, because we have our LINAC with the KV tube outside, the panels outside, everything will be between the cameras and the patient itself. So we did a measurement of the line RT signal, how will be affected along the completely rotation of the gantry, and we identify all these 3 regions, that with the reasons that you can see with these gray areas. That is, for example, the case when you have the KV tube in front of one of the cameras, when you have the gantry in front of another camera. Anyway, this impact on the signal is around 1 millimeter, so it's something that when you are monitoring the patient and you see that the patient is not outside tolerance but have a larger deviation, but inside tolerance around 1-2 millimeters, you can see that it's not a patient motion, but it's because of the location of the gantry during this time of the acquisition. So we are going now to evaluate how can we irradiate these patients. So first we spoke about the impact during the imaging part, and now during the radiation. One of the factors that we'll have is this blocking of the gantry. We can have different gantry blocking effects depending on where it is located the tumor, how was defined the ROI, if the ROI is more from the left side, from the right side. This is one of the examples, the worst cases, that we can have up to 2 millimeters difference in some specific regions. This plot is a gantry rotation along the completely 360 degrees, and you see some magnitude variations, not because of the motion, but because of the blocking of one of the cameras. So this result this impact can go up to 2 millimeters in the worst cases, but it's interesting to see that for each LINAC, you can exactly define where is this region. The amount of this impact can be different depending on the ROI and everything, but the region where you have this effect is always the same region. Also, sometimes for SBRT patients, we are also rotating the coach, so it's also important to understand how will be our signal affected from this impact. This is a measurement where we have something without any motion, so these results are only from a simple cube and the coach that is being rotated. So if you use the normal calibration, the normal plate calibration that we have for a line RT, we can have in our system, in one of our LINACs, we can have up to 2 millimeters when we have 90 degrees or 270 degrees for the couch angle. But if you include this new calibration that you are going to include the information from the MV, doses, then you can reduce your uncertainty from your system below 1 millimeter and consider that you can use some couch rotations for some patients, that the results, that the deltas that you are going to obtain are not from inaccuracies from the system, but from the motion of the couch or the patient itself. More important is that when you are doing the planning for these patients, when you are selecting the beam directions, that you need to consider that if you want to rotate the couch, you need to know where is the gantry. So normally you only take care that there is no collision between the two, but now that you have a line RT that needs to see the patient during the entire treatment, it's also important to consider that if the camera are able to see the patient when the couch is rotated. So it's important to avoid combinations of gantry and couch angles where you have a strong signal reduction. So regarding the definition of the ROIs, so it's important to define a location that is representative from the breathing, but also from the tumor, that is less impact due to the gantry or coach rotations, cannot be too small ROIs, otherwise you don't have enough statistics, but not too big because you'll have some reduction of the overall signal because it's a too big signal and the system will be a little bit slower. This is a short overview that is the definition of ROI are really, really important. For example, if you compare the case A and the case B, that you have the same region of the patient, but ROI that only consider one side of the patient or the entire thorax. You can see below, comparing the dark blue and the green colors, that you have a different signal. Of course, because you have a larger ROI, you are reducing your signal, and you'll have for sure another motion that will be evaluated by the system. So it's really important to avoid a ROI that is not significant of your patient motion. The same happens when you select a small ROI, as example at D2 and the D1, that you see that is if you have a larger or smaller ROI, you'll have a signal that can be completely not relevant. So for our case, we defined that our patients will be treated with this ROI here because it's the best commitment between the size and the location. So you will have something representative from the breathing of the patient, something not too big to avoid that you are including another motions from other reasons that are not relevant for the tumor. And some also important remark that I would like to do, that is really important that the patient have some kind of structure, some kind of contour. If you have a patient that have a lack of some contour, some gradient, you can have some inaccuracies in your signal, and you need to pay attention and define maybe another ROI, try to get another strategy to improve the accuracy of your system when you have lack of contours. So pointing that, now we are in the point that we can define our workflow. We can define our standard operation procedures for our SBRT patients. So as I said, all the patients will be trained in the IBH. At the CT acquisition day, the CT will be performed also in deep inspiration, as well the planning will be done in using this CT. At the treatment day, the patient is first positioned at the reference point. The patient is then aligned at the isocenter using the DICOM surface. In this step, we are already giving the breathing command to the patient. The CT will be done, performed also in deep inspiration. If you have some shift, we apply a shift to the patient. Afterwards, you will do some control imaging. That can be a second chromium CT, MV or KV. And simultaneously with this second imaging session, we are going to make your acquisition of your reference, of your LNRT reference. If everything is okay, so we can review the ROIs and treat the patients. And then we started treating the first patients. So one of the first points that we wanted to assess is how is the tumor positioning reproducible from day to day, and from between the beginning of the treatment and along the treatment. So for that, for the majority of the patients, we did 2 chromium CTs to confirm if the patient is able in 2 different times to reach the same breath hold state, if the tumor position is the same in 2 different moments. Also from the MV or KV acquisition, we can also assess if the DIBH is the one that is the correct with the planning. Also for all the patients, we did the evaluation, how is the daily column beam CT shift to assess how robust is the positioning of the patients along the treatment. This is one example of one of the patients. Each of the yellow points are one of the treatment sessions. For this case, this is abdominal patient, and we can see that in mean the variations along the entire treatment was around 0.8 millimeter, and the maximal variation of the motion, the maximal shift between the planning CT and the column CT for one day was 1.5 centimeter. We also did the evaluation, how is this deep inspiration state from day to day changing. For that, for each of the patients and for each of the column beam CT was defined a fixed point, something at the vertebral discs or something that is really fixed every day, and a point in a moving landmark that can be in the tumor, a clip, something like that. And for all the patients, we got that the mean variation around 0.5 millimeters plus minus 3 millimeters. So that means that we can get the same DIBH state from day to day within these with these mean variations. Regarding the evaluation of the implementation process, we also asked the patients how is the compliance with the treatment. We tried to make staff training to include all the groups, to include refreshment of the training, how is the workflow. The treatment time was also improved along comparing the first patients and the last patients. And if you want more details about this and implementation from the SBRT, from the clinical perspective, and all the evaluation from this robustness and from the DIBH from day to day, you can see in the poster or ask me later. So in conclusion, Align-RT was accepted to treat SBRT patients under DIBH and daily imaging with a really good accuracy. It's really important to define a LINAC-specific commissioning, because every LINAC, not only if it's electro-ovarian, but also each installation have own requirements, own limitations and specifications. That need to be included in the treatment protocol, in the planning, irradiation techniques. If you can rotate the coach, if you can reduce your margins, everything needs to be included. The evaluation of the first patients showed a good agreement between surface and tumor, and it's really important to have this interdisciplinary training. And the clinical phase 1 trial is in preparation. So thank you for your attention.